Hello, everyone, and welcome to the Academy of Eating Disorders webinar entitled Current Strategies for the Treatment of Avoidant Restrictive Food Intake Disorder in Higher Levels of Care. 4 topics, 4 centers, with Drs. Sarah Eckert, Jesse Menzel, Nicholas Farrell, and Marcus Westerman. My name is Julie Lesser, and I am your moderator today. Also with us is Ronald Phan, who's AED's membership manager. If you have questions or concerns about the webinar, please feel free to reach out to Dawn Gannon at AED headquarters via email at dgannon@aedweb.org. Just a couple of housekeeping items and then we will get started. All participants are muted with the exception of the speakers and myself. The webinar is scheduled for 60 minutes and it is being recorded. It will be posted on the AED website for AED members to download at their convenience 24 hours a day, 7 days a week. In just a few minutes, Drs. Eckert, Menzel, Farrell, and Westerman will begin the presentation, after which they will answer questions from the audience. Please feel free to submit your questions to the speakers during the presentation using the chat text box on the bottom middle of your screen, and I will read them to the speakers when the question portion of the webinar begins. This is the box that is for Q&A. Let's check the volumes quickly for our speakers. Dr. Eckert, would you please say a few words? And then if a couple of participants would please let me know if they're able to hear them clearly by sending a chat text box message, then we will get started.
Hi, this is Sarah here.
If someone would just please let me know if you're able to hear her, that would be great. And okay, thank you. Next, Dr. Westerman.
Hello.
Hello. Okay, and now Dr. Farrell.
Hi, this is Nick.
Great. Is Dr. Menzel with us now? She's arriving is what I understand. I think we'll go ahead with introducing the speakers, and then I think she will be joining the panel shortly. So I want to first of all thank everyone for attending and helping with this webinar. I would like to begin by introducing myself and our speakers. I'm Julie Lesser, I'm an MD, and I'm a child, adolescent, and adult psychiatrist at Rogers Behavioral Health in Eden Prairie, Minnesota. I received my medical degree training, internship, residency, and fellowship from the University of Minnesota. I've specialized in treating patients with eating disorders for the past 15 years and completed the supervisor level training in family-based treatment, along with training in cognitive behavioral therapy and the unified protocol. My main interest is in how to adapt and implement evidence-based practices in higher levels of care and for patients with comorbid conditions. I have the pleasure of serving as the co-chair with Dr. Menzel of the Child and Adolescent Special Interest Group for the Academy of Eating Disorders. Now, on to our speakers. Our first presenter will be Dr. Sarah Eckert, who's a PhD and a licensed psychologist at Children's Minnesota Center for the Treatment of Eating Disorders. Her clinical interests include developing new and innovative treatments for avoidant restrictive food intake disorder, which I will call ARFID from this point on, and also in the treatment of eating disorders using both family-based treatment and cognitive behavioral therapy enhanced. She is certified in family-based treatment and in the unified protocols for the transdiagnostic treatment of emotional disorders in children and adolescents. Dr. Marcus Westerman is an MD PhD and an adult child and adolescent psychiatrist at the Melrose Center in Minnesota. He specializes in the treatment of eating disorders with patients in all levels of care, outpatient, partial hospital, and residential. He received his doctorate of medicine from the University of Minnesota and also completed his psychiatry residency and child and adolescent fellowship at the University of Minnesota Medical School. Prior to going to medical school, he received a degree in neuroscience, and that was also from the University of Minnesota, and he is published in the Journal of Neuroscience and also Psychiatric Times. Our third speaker is Dr. Nicholas Farrell, PhD, who is the campus clinical director at Rogers Behavioral Health in Oconomowoc, Wisconsin, where he provides clinical leadership and direction for psychotherapy services, including the ongoing development, implementation, and refining of the clinical protocols. In this role, he works with the medical and clinical leaders across the system with the aim of maximizing treatment effectiveness and improving patient experience. Dr. Farrell supervises the eating disorder programs in Oconomowoc. In this role, he provides training and guidance to clinical team members in the eating disorder recovery residential unit, as well as the inpatient, partial hospital, and intensive outpatient levels of care. He received his master's and doctorate degrees in clinical psychology from the University of Wyoming and completed his pre-doctoral internship training at St. Joseph's Healthcare in Ontario, at Hamilton in Ontario, Canada. Dr. Farrell is one of the lead architects of the exposure-based treatment at Rogers, and this is a transdiagnostic treatment adapted for all ages from children to adults. So he specializes in the use of empirically supported treatments for eating disorders and co-occurring anxiety and mood disorders. He's co-authored many peer-reviewed articles and given presentations on topics related to the cognitive behavioral treatment of eating disorders and anxiety disorders. Dr. Jessie Menzel is PhD, is an assistant clinical professor in the Department of Psychiatry at the University of California, San Diego. She is the founder and director of the Pediatric Clinic at the UCSD Eating Disorder Center, a specialty partial hospital program for children ages 7 to 12. Dr. Menzel has extensive treatment experience working with children, adolescents, and adults with eating disorders at all levels of care. She provides training and supervision to postdoctoral fellows, psychiatry residents, psychiatry fellows, and therapy practicum students as part of the UCSD EDC training program. Dr. Menzel has published numerous research articles and book chapters in the fields of ARFID and related eating and anxiety disorders. Her current research interests include understanding the etiology of avoidant restrictive food intake disorder, with particular interest in the role of disgust, visceral hypersensitivity, and the neurobiological motivational systems that regulate food intake. She is currently serving as the co-chair with me of the Child and Adolescent Special Interest Group for the Academy of Eating Disorders. So with that, I would like to turn this over to Dr. Sarah Eckert, who is our first speaker.
Thank you, Julie. So I'm sorry that I'm having a moment with the slides here. There we go. I'm going to start talking today about the inpatient treatment of ARFID, specifically treatment within a hospital setting. And so, as Dr. Lester said, I'm a part of the Center for the Treatment of Eating Disorders, which is within and housed within Children's Minnesota. We have two campuses, one in Minneapolis and one in St. Paul. And I have no disclosures, but I am just talking here about confidentiality as well for children's. This slide just gives a little bit more information about the hospital admission criteria we follow. So because this is a children's hospital, we are following the American Academy of Pediatrics inpatient criterion for admission and discharge. And I would say in general for ARFID patients, the most common reason patients are admitted to our unit are either for a very low weight. So as you can see on the far left, less than 75% of an estimated body weight. Again, we are using the 50th percentile for estimated body weight per the guidelines. Other than that, another common reason for admission might be rapid weight loss due to possibly a choking phobia or a fear of vomiting that maybe led to the patient stopping eating all food, and that led to rapid weight loss, or really acute food refusal for more than 3 days, as well as low heart rates or other lab abnormalities. So the goals that we have at Children's for our inpatient unit, So just to be clear, we're a blended unit. So we have patients on our unit with all eating disorder diagnoses. So ARFID patients are mixed in with other eating disorder patients. And actually protocols are largely the same as we follow for our other eating disorder patients. This is considered to be an acute intervention, and our sole focus is on medical stabilization. But during that time, we're also working on a lot of other goals with our patients. We're focused on establishing a regular eating pattern is a big part of this hospital stay, as well as regaining weight for patients that are underweight of at least 2 to 3 pounds a week. And I would say the majority of our patients are being admitted due to low weight or weight loss, but occasionally we're also seeing patients that are not underweight, but that have had just a really rapid acute food refusal or another major abnormality with labs or other nutritional deficiencies that we're trying to correct. And we're also trying to help the families to prepare to start outpatient treatment and to set them up for success. And that sometimes includes stepping down out of our program after this to a place such as Melrose, which Dr. Marcus Westerman is going to talk about next, or another outpatient treatment facility in the community, or to our own treatment center where we have our medical unit for inpatient and then our outpatient treatment center. The average length of stay for our patients is around 10 days. And as you can see, there's a lot of different people that are a part of our inpatient team here at Children's, and a lot of interesting different professions such as integrative medicine, dietitians, hospitalists, child life staff members. On the right is a picture of our unit and actually one of the rooms where the patients have their meals. On the left is actually a place called the Child Life Zone, which is a place where our patients can go, and they're actually with other patients within the hospital, and they can do games. There's a studio there where they can do recording. There's a photo booth. There's all kinds of different activities, and it's actually been very helpful for our patients outside of meal times to have just a normalized kid atmosphere to be in. So what are our patients experiencing while they're at Children's? Every patient is getting really significant medical monitoring and management by a hospitalist team, including with the eating disorder specialist on our team. So regularly they're having EKGs, electrolyte monitoring done. Every patient is on telemetry on our unit for at least a minimum of 72 hours in order to rule out any sort of cardiac issues. And then daily we're rounding with our team and the families. And we really encourage families as much as possible to be present in the hospital. And actually all of our rooms are individual rooms. And so patients can actually stay in the room with their parents, and they have a private bathroom, a private room for their family. Every patient is also getting assisted meals, which includes 3 meals and 2 snacks per day. And I'm going to talk a little bit in a second here about how we modify our meals and snacks slightly for our ARFID patients. But in general, like I said, they're eating with the other eating disorder patients on the unit. And we found that that's actually been very advantageous, that actually the patients really help and support each other, and that our ARFID patients can support our anorexia patients and vice versa. They're also receiving a lot of activities from our child life staff members around child development. They're having psychotherapy groups, a lot of help from our integrative medicine team to learn things such as breathing techniques, the use of acupressure, other kinds of things like aromatherapy, and different techniques that they can use to help with pain, fullness, etc., that are a lot of our ARFID patients experience. And then finally, every patient is going to have, before they go home, a family meal and dietary education with our staff. Our treatment model that we have followed at Children's since this center was set up actually by Dr. Julie Lester about 5.5, 6 years ago, we've always followed a family-based treatment model. And that means that we are using parents as our main resource and trying to help educate parents and our children about the effects of being underweight, and always prioritizing the need for weight regain up front. And as the patients are regaining weight, then we start to work on variety. And that may or may not be while they're in the hospital. Very frequently it is while they're still in the hospital, but not always. We're also preparing the parents to be able to be in charge of helping their child to regain weight after they leave the hospital, and then starting those therapist-assisted family practice meals that are part of FPT. The other piece of our protocol that we are following at Children's, and that we've been following, as I said, for the last 4.5 to 5 years, is working together with Dr. LaGrange from the family-based model and with Dr. Jill Ehrenrich May, who is from the University of Miami. and who was one of the original authors on the Unified Protocol for adults, and has now actually translated that treatment protocol for children and adolescents. And so we have been using that protocol together with FBT. We have called it FBT plus UP for our patients for the last 4.5 years. And we're actually very soon going to be wrapping up a study we have been doing, looking at our treatment model, and hoping to be publishing very soon about the results. And so this includes using the Unified Protocol, which is a transdiagnostic treatment. It's a CBT treatment that we incorporate into FBT, which gives a lot of information on psychoeducation about our emotions, helping the patients to understand their body cues and their body clues, helping them to see kind of what's happening before, during, and after an emotional experience and or a fear around eating. We work on thinking traps, helping patients to be non-judgmentally aware, which means obviously being able to be more accepting of foods, regardless of whether or not they like them, that we never make a patient have to like a food, but to be able to tolerate more foods and tolerate those feelings that their body gets in situations such as disgust, etc. And then a lot of work on exposure. And again, as I was saying, this is work we start in our inpatient unit, but a lot of times are also continuing in our outpatient clinic. And then every family is getting dietary education as part of their treatment at Children's. So we are spending a lot of time with families discussing general calorie goals. And because patients are with us a short amount of time, we are fairly aggressively refeeding our patients. Most patients start on 1,500 calories when they first walk in the door, and by the end are up to 3,000 plus calories before they leave. And we're moving at about 500 calories every 1 to 2 days. And so by the end of the time that they're with us, the families will be able to know how many calories approximately that their child needs in order to go home and to continue regaining weight. We also talk a lot about the need for additional calories through food because of their child being hypermetabolic. And so giving them a lot of education on different ways to add energy density to the foods. We give handouts on this and review different additions we use in our hospital to the foods and ways that the parents can do this at home to be able to be successful. We also talk a lot about schedule changes. Many of our ARFID patients have not been eating on a helpful schedule, or they've been missing meals. And so working with families to kind of put that structure into place. And then finally, making just really small yet significant changes. Again, as I had said before, a lot of our patients are going to get a pretty extensive medical workup, and we consider ARFID to be a diagnosis of exclusion at Children's. And so we never start with the expectation that a patient who is being referred to us automatically has ARFID. And a lot of times we have to do a lot of workup to rule out other medical issues. And we have definitely had patients who have been admitted to our unit that have ended up having things like celiac. And so again, reminding us that we need to do good extensive medical workups through GI. We might also involve other types of programs within the hospital, endocrinology. We may be looking at working with a speech therapist or an occupational therapist if there are problems related to swallowing or textures or things like that as well. So that's the great thing about being in the hospital setting. The biggest differences in how we treat these patients. So one important thing is that we allow for more dislikes. And so with our anorexia patients, we really only give them 3 dislikes in the hospital. We are more flexible with our ARFID patients. We also will frequently use alternative replacements, such as instead of using Boost or Ensure that we would use with our other patients, they might use peanut butter and jelly sandwiches or something else that's a preferred food. We also use a lot of rewards and then just more flexibility overall. Here's just an example of a star chart we might use on the unit, and we will use rewards related to completing a meal more quickly, so decreasing the time it takes for a patient to eat or trying new foods. And then my last slide here is about medication. So as we know, there are no medications that are currently approved or tested for ARFID. We are still trying to do more research on that. But one of the most common medications we use on our unit is hydroxyzine, and we use a very small dose for patients before breakfast, lunch, and dinner. And actually I found it's been very helpful for managing that premeal anxiety or nausea and fullness that a lot of our patients with ARFID experience. And then not uncommonly, some patients are on cyproheptadine to help with either increasing appetite or possible gastroparesis. And then finally, sometimes SSRIs that we're using to help if there's a co-occurring anxiety or depressive disorder, as well as very occasionally olanzapine or mirtazapine. I'm gonna turn it over now to Dr. Marcus Westerman.
Hi, this is Marcus. So I'm going to talk quickly about the treatment of ARFID in our residential treatment. This is a slide describing Melrose Center. We have what we call intensive residential and residential beds, as well as PHP and IOP. And as you can see, we have a full treatment team that we work with. Let's see here. And, recently over the last year or so, we took a lot of feedback from our patients, our ARFID patients, about their treatment. And we've really been aggressive and passionate about an initiative of really changing how we're helping our ARFID patients. Similar to children's, we have an integrated unit where there's patients of all eating disorders on our unit at any one time. But we've worked, again, over the last year or year and a half to change things sort of specifically for our ARFID patients. And I'll talk more about that. So with that initiative, that really went live in March of this year and has been going really well. I'll defer in terms of admission and discharge criterion, since Dr. Ector did such a wonderful job kind of describing those things. And I know the other panelists will also. So I'll just go ahead and kind of talk about, well, I don't know where that came from. Looks like it skipped ahead. But what we have, we do some tracking, so I also put that in there. Of importance, we recently did some training for the PARTY, which is the PICA, ARFID, and Rumination Disorder Interview, for utilizing that in integrating and kind of checking outcomes, because some of the other measures have been inherently somewhat difficult to get kind of information on how our ARFID patients are doing. But what we worked on in Point is something called CBT-AR. This was recently published as a manual for treatment, cognitive behavioral therapy for ARFID, developed by Drs. Thomas and Eddy. And we had training with them, with our staff here about a year and a half ago, and have had continued ongoing supervision with them. And we've utilized this treatment for a number of reasons. One, it can be utilized for both adults and kids and adolescents, and it actually works really well in terms of a smooth transition from higher levels of care to outpatient care. One of the things that it uses is a workbook that the patients actually get when they're first admitted, if they are admitted to intensive residential. And then that can pass along to the therapist that they continue to work in outpatient care. There's 4 stages to CBT-AR. The first is psychoeducation, establishing regular eating. And it's important to keep in mind that with our child and adolescent cases, really the only criterion, or the main criterion for admission with ARFID, would be malnutrition or low weight. And within stage 1, CBT-AR actually defers and utilizes a family-based treatment to work aggressively at restoring weight in the first period of treatment. So in a way, the default ends up being FBT for that first stage. And most of the time when especially with the kids and adolescents that get admitted to intensive residential, we're really working with the core of FBT with some alterations, which I'll discuss in a minute. The second phase is really treatment planning. That's figuring out what the malnutrition issues are, if there are specific vitamin deficiencies or things like that, and kind of navigating what foods we're going to target. We have wonderful dietitians here that can kind of help support that also. The third stage is really different modules of exposure. We know that ARFID is often described in 3 different categories, either low appetite and lack of interest in food, sensory issues, or fear of aversive consequences. And CBT-AR has modules for exposure techniques in all of those different types. And we also know that there's an overlap between all of them. I often find that, eventually throughout the process of ARFID, that a lot of times those patients have multiple of those, and so you can kind of utilize all those exposures, but it's really a process of exposure. And then stage 4 is relapse prevention. But one of the main modifications in terms of residential care, and one of their sort of mantras, is working with volume before variety, and that's really within that first stage where you're working on weight restoration and utilizing FBT strategies to do that. So a lot of times in residential care, what we're finding is that we're initially working on, again, the volume over variety. We do a survey. The dietitians meet the patients and or their parents right away and map out their preferred foods and try to work within those boundaries, as well as starting some exposures, because we often find that having that structure can really help with that initial exposure, especially when the patients are pretty motivated. But also, again, working on the volume to get the weight restoration to happen. A lot of psychoeducation. And then if they are in the residential for a longer period of time, a lot of times we're also starting that stage 3 with exposure. But again, the primary goal in an intensive residential or residential for these ARFID patients is restoring weight. The secondary goal is increasing variety. I don't mean that in terms of importance, because obviously increasing variety is a big part of it. It's just that if they are in that intensive residential or an inpatient type setting, they're there for restoring weight and malnutrition. We work on that increasing variety with time. This is some of the adaptations in terms of our multidisciplinary team that we worked at. The therapist really does the overall delivery and implementation. They administer individual behavior plans. The dietitians will complete a list of preferred foods and do a meal plan with the preferred foods and partner with the patients in OT for food exposure. We have mental health providers that do early focus on developing skills for physical discomfort, and we've modified things to have more one-on-one and small groups for strategy and behavior. And then our OT providers partner with the patients and RD on food exposures, as well as facilitate an ARFID meal group and have a significantly larger role in treatment. This is just, I did a couple slides just to kind of show the differences. You all may know in terms of the patient's focus that there's a big difference in terms of ARFID. A lot of times there's limited or no body image concerns. They may be motivated or even happy about gaining weight, maybe okay with higher calorie foods. We'll have patients that go for outings and they're getting a Frappuccino and the anorexic patient is in tears and the ARFID patient is asking for more. So we know that there's that difference and we want to support that and help them support each other. Oftentimes there's a lot more focus on physical sensations related to eating and fullness, and so we work a little bit more on that one-on-one. And also they may struggle with sensory issues, fear of aversive consequences, nausea and vomiting. So with meals, really things are pretty much the same in the sense of how we treat these patients, with some exceptions. So I put those in red. Patients, they will start on preferred foods, and the meal plan will tend to emphasize caloric intake. Otherwise, again, the family is involved for support and discussion. They work with the RD to create a meal plan, and the meals and snack times are the same for all patients. In terms of programming, we've made some modifications also. So these are sort of specific to our program, but I think it's worth pointing out that, rather than doing some of the behavioral change or body acceptance things that adults may have, we will do with the adult patients some one-on-one or mini sort of behavioral change groups with an MHP, and still using things like behavior chains. We'll do individual family sessions, and we actually do kind of an ARFID meal group, oftentimes combined between the adults and the kids and adolescents, and focusing a little bit more on one-to-one or sort of mini strategy groups for goal setting, and also working on exposures. Let's see here. In terms of family involvement for adolescents, again, we focus on the FBT for weight restoration. And again, that tends to be the primary focus on when they are in an inpatient setting. But the patient may be more involved in determining the preferred foods initially. In terms of level of care, I already mentioned we kind of utilize that CBT AR workbook to allow the transition from higher level to lower levels of care. And we'll save questions for the end. So thank you.
Okay, well, I want to first start by thanking everyone for viewing this webinar. Thank you also to Julie Lesser and my co-panelists for organizing this and putting it together. My name is Nick Farrell. I'm the clinical director of our Oconomowoc campus at Rogers Behavioral Health, which is our main campus located in Wisconsin. I'm very excited to present on this topic. You've heard a couple of my colleagues discuss this idea of exposure. So what I'm going to be discussing, I'm going to go into a little bit more depth in discussing the use of exposure therapy in the treatment of ARFID in higher care levels. And this is a technique that we use frequently in our programs at Rogers at all levels of care, from inpatient all the way down to IOP. I want to start by saying that even though exposure is considered predominantly a cognitive behavioral treatment strategy, we very much believe it's an approach that can be integrated into other treatment modalities. So even though it very much, exposure therapy has a rich history in cognitive behavioral traditions, we see a lot of examples now where it can be very feasibly integrated into different treatment approaches. So I'm going to start with reviewing a number of reasons why exposure is a very good fit for ARFID. And many of these reasons, as you'll see, involve some really key transdiagnostic features that are shared between ARFID and many other anxiety and fear-based problems. So we'll start with one that won't surprise you, and that's the fear of significant negative consequences. And certainly we see this in a number of our ARFID patients, whether the fear concerns a choking episode, uncontrollable vomiting, or the development of other serious medical complications or problems. And going along closely related with that, there is on the part of patients a lot of avoidance of feared stimuli in ARFID, whether that's the types of food items or selections that tend to evoke a lot of the sensory aversions that patients with ARFID experience related to either the taste of food, its smell, or even the texture, as well as just general food amounts or quantities that may evoke GI-related distress, kind of fullness or bloating sensations or similar types of sensations. And even things like eating in a relatively normative manner, normalized pace, normalized size of bites, that sort of thing. So these are all collectively types of avoidance that our patients with ARFID experience. When avoidance may not be possible for patients with ARFID, we see a host of other behaviors that we could kind of put under the umbrella term of safety behaviors. And these are behaviors that are aimed in some way, shape, or form at trying to prevent a feared outcome from occurring. So for example, a patient may excessively chew their food to the point of, kind of like grinding it down to a paste almost, with the aim of trying to prevent a choking experience. There can be overuse of certain medicines aimed at trying to prevent the experience of fullness or nausea. Similarly, we might see things like where a patient holds their nose or engages in other similar strategies aimed at trying to prevent anticipation of disgust sensations related to the taste or smell of food. And then finally, last but not least, we see a heightened degree of sensitivity and perceived intolerance of these aversive states, whether we're talking about disgust sensations, gastrointestinal distress, or even other feelings that might be associated with the taste or texture or smell of certain foods. So in summary, what many of these common features, I'm sure most of us are familiar with in ARFID, we also see these very much present in people who struggle with comorbid anxiety-related problems. And the good news is that this kind of bundle of transdiagnostic features can and often is very successfully treated through the use of exposure therapy. Common examples would include in vivo exposure to address, anxiety and avoidance related to feared stimuli, whatever that feared stimuli might be, as well as interoceptive exposure that is aimed at trying to address fear and avoidance of different bodily sensations, whether they're anxiety related or related to gastrointestinal distress. Finally, there's other forms of overlap between ARFID and anxiety and related disorders, not only in terms of their comorbidity, so we know that they tend to co-occur quite often, but we also know that in addition to there being this kind of shared set of key transdiagnostic features, the interrelationships among these features is very similar in terms of how the disorder plays out from a maintenance standpoint. That is that across both ARFID and anxiety and fear-based disorders, the patient's avoidance of feared stimuli, as well as their use of safety behaviors, kind of combine to prevent the patient from acquiring inhibitory learning and improved toleration of their distress. So I'm going to segue now into talking about a couple of really key important steps that we use in rolling out exposure-based treatment for ARFID. The first is completing what we call a functional assessment, probably a little bit different from other more diagnostic forms of assessment, in the sense here that our major goal is to identify some key cognitive and behavioral features of our patient's ARFID symptoms. And this is a really important treatment step because it essentially forms the rest of the treatment plan that follows. So there's three key domains that we assess in the context of a functional assessment. The first being feared cues. So we're trying to here ask the patient questions along the lines of, what are the types of things that cause distress for you? What evokes your fear or distress? Related to that, we're trying to ascertain what are the patient's anticipated feared consequences. So questions that we might ask include, why is it that you fear or avoid these kind of things? What are you concerned could happen to you if you were to stop avoiding this activity, this food, experiencing this sensation, whatever it might be? And then third, finally, we're trying to get a sense of what the patient's safety and avoidant behaviors look like. So when you're faced with this fear, what is it that you try to do to try to prevent your feared consequence from occurring? And again, the goal there is to, in collaboration with the patient, determine the functional relationships between these domains. So on this slide, I've just included a couple of examples of what at least some aspects of a completed functional assessment might look like. You can see in the first example that goes across the first row, the feared cue that's identified is broccoli. And the patient has hypothetically here identified a feared consequence that if I were to eat broccoli, I would be so disgusted, maybe it's by the taste or the smell or the texture of it, that it would result in me vomiting uncontrollably. And so this patient has identified that their major safety or avoidant behavior is pretty simple and straightforward, and that's to avoid eating broccoli. Similarly, let's walk through the second example. The feared cue might be popcorn. And in this instance, the consequence would be, well, the popcorn's going to get stuck in my throat and I'll suffocate. And so the safety behavior, it's not very depicted well by this illustration, but would be a very slow, meticulous, highly cautious way of eating the popcorn, kind of one piece at a time. Dietary exposure is really kind of the main thrust of exposure-based treatment when it's applied to ARFID. So in our programs, the therapist as well as the dietitian collaborate closely with the patient. And when it's a young patient, we certainly involve parents in the planning of treatment. And the collaboration is done to create what we call a hierarchy, which is just a master list of different feared and avoided eating scenarios. So common examples might include exposure to the feared quantities or portions of food, as well as the feared food items themselves, and even other types of exposure to various normalized eating behaviors, whether it's trying to eat at a try to eat normal-sized bites of food or consuming food at a normalized pace. And when we create this hierarchy, our aim is to start with moderately fear-evoking exposure and gradually move our way up. So a motto that we kind of live by at Rogers is challenging yet manageable. We need anxiety to be present in the room for the exposure to be effective, but not so much that the patient anticipates or anticipates that they wouldn't be able to even have success with the exposure. And this is a really critical piece because that helps a lot with getting initial buy-in and kind of getting the patient on board with treatment. And so our major goals are trying to facilitate violation of the patient's fear expectancies, as well as promoting increased toleration of distress related to the sensory aversions that patients might experience. A couple other types of complementary exposure. Beyond actually consuming food, we may encourage exposure with other food-related interactions, whether it's just coming into contact with, touching, or holding food items that yield textural aversions for our patients, or even smelling or licking certain foods that have kind of a taste or a scent-related aversion. And then working our way up towards eating smaller quantities of food with gradually adding more. Interoceptive exposure, the type of exposure that we might use to kind of artificially induce body sensations, can be very helpful in helping our patients try to acclimate and develop improved tolerance to these sensations. So common examples that we might use: having a patient quickly drink a carbonated beverage to induce sensations of fullness or bloating, as well as swallowing repeatedly to induce a sensation of throat closure. And last but not least, we might encourage a patient to stand and slowly spin in circles with the aim of inducing a nausea sensation. So in summary, there's certainly a lot of comorbidity as well as content overlap when we look at some of the key transdiagnostic features shared between ARFID and anxiety disorders. Based on that, exposure therapy appears to be a very highly applicable treatment and very feasible for ARFID at all levels of care. This can be used as a standalone intervention or as an adjunctive intervention to a number of our other evidence-based treatment protocols, including cognitive behavioral therapy and family-based treatment. And then last but not least, we take a lot of confidence in the graduated nature of the treatment, as this really seems to do us some good with facilitating patient buy-in and cooperation at all steps of the treatment. And with that, I will turn it over to Jessie Menzel.
All right, hi everybody. I'm Dr. Menzel and I am the Director of Pediatric Services at the UCSD Eating Disorder Center. So my colleagues on the webinar today have provided a really wonderful overview of some great approaches to treating ARFID at these higher levels of care. I'm today really going to be talking about working with younger patients specifically and how we're incorporating family into that work. My clinic, just no commercial relationships to disclose, but my clinic falls here over on the kind of behavioral health side of intensive approaches to treating ARFID. As many of you probably know, ARFID is not a new disorder per se. It's this evolution of the feeding disorder of infancy and early childhood. And so many of these patients in the past were kind of subsumed under more medical services. So feeding disorder clinics kind of live under the medical side of the insurance billing world. They're often embedded within gastroenterology clinics or speech and language pathology clinics. So this is sort of the domain in which intensive treatment for ARFID has historically occurred. And so now these are patients that were oftentimes having comorbidities with complex medical issues, whether that be short gut syndrome, genetic abnormalities, birth defects, severe developmental disorders, or children that relied on enteral feeding, so tube feeding either through a PEG or through an NG or NJ. Many of these patients have historically been seen through these clinics and treated at this level of care. These patients also tended to be very young. So most of these clinics that are functioning today are typically seeing children as early as infancy through early childhood, so ages 4, 5, and 6. So there's a little bit of a gap in care here for between these very, very young patients and the age group of patients that we typically see in a behavioral health setting or a traditional eating disorder, PHP or IOP. So on the behavioral side of things, we're seeing these kind of older ARFID patients that have more psychiatric comorbidities or significant anxiety component. And we're also seeing, again, like I said, this sort of missed age group of children that fell within that sort of later school-aged pre-adolescent range. So at our pediatric program, this is sort of the group of kids that we set out to really target or capture. So in our partial hospital program, which runs 5 days a week for 6 hours per day, our kind of bread and butter are these kids ages 7 to 12 that fall sort of in the younger spectrum of traditional eating disorder care, but in the older spectrum of more traditional medical feeding disorder settings. We use the multidisciplinary team approach. We have psychiatry, psychology and therapy, dietary and nursing at our clinic. So the ages that we're seeing, so in our younger cohort of ARFID patients, we're seeing about an equal 50-50 distribution across the genders. And we're also seeing, again, low body weights, as Marcus Westerman was talking about. You know, one of our primary goals here is increasing weight. And so most of our patients are significantly weight compromised, coming in at about 85% of their estimated body weight. We're also seeing a lot of comorbidity with anxiety disorders. So generalized anxiety disorder, unspecified anxiety disorder, OCD make up the bulk of our comorbidities. But we're also seeing a large percentage of kids that have been diagnosed with attentional deficit hyperactivity disorder. Not as many of the developmental disorders, as I think they mostly get subsumed under more established autism treatment settings, or again, within those traditional feeding disorder clinics. Okay. So the components of the treatment that we're using for this group of kids are some that have been described by others on this talk today already. So we use that structured mealtime setting to target increased intake, weight restoration. We use it as a setting for exposure for new foods. We're individually tailoring meal plans to meet the preferences or the stage of exposure for our patients. Family involvement is huge, so we have parents participate for an average of 8 hours per week in therapy, so they attend a whole 6-hour day at our clinic, as well as family-based sessions during the week as an adjunct to the partial hospital day. And this, again, is largely to provide that family with psychoeducation, both on reasonable treatment outcomes, but also to incorporate them in aiding the weight restoration process. CBT-oriented group and individual therapy to challenge fears and teach coping skills, and a lot of contingency management and escape extinction in our program. When working with young kids, both in a feeding disorder setting, but also in our setting, we're really relying on some of those basic behavioral principles of reward, antecedent manipulation, to increase the likelihood of success for our kids, and also to motivate them to participate in what can often be a very aversive treatment for them. And finally, medication management, psychiatric medication management, with many of our targets being anxiety or better managing ADHD, so that we can help kids focus better at completing meals, but not impair their appetite to such a degree that they aren't feeling those hunger cues or early satiety. We also are targeting with meds visceral hypersensitivity. So many of our kids have functional GI disorders or functional GI complaints. And we're finding that medications like Remeron are often very good at relieving nausea, feelings of fullness, and just improving overall motility in these patients, which usually leads to increased intake and increased weight gain. So why do we emphasize this family-based approach to ARFID? Well, there's this very young average age at the presentation to treatment. So overall, our ARFID patients are much younger than our AN patients. I believe the average age in our clinic is 10 years old. And also, family-based approaches have been shown to be very successful in the treatment of childhood eating disorders. As our goals align in the treatment of anorexia and ARFID, this prioritizing weight restoration, FBT seems like a natural fit in achieving that goal. It works very well for AN, and so we're borrowing from that successful treatment and applying it here to ARFID. We also really like FBT because of its emphasis on empowering parents to take charge of child's eating. This is often counter to some, I'd say, more traditional approaches like SOS feeding therapy, which emphasize letting the child have the freedom to choose, providing the child with a wide access of foods to try, but not putting any pressure on the child to try foods. We think that's a great approach to sort of normative picky eating, but when you add in poor appetite, maybe like poor interoceptive awareness, low body weight, the kids are not going to just naturally push themselves beyond those natural signals that they're feeling in their body. So we really need to shift this dynamic from having the child be in charge of the eating to having the parents be in charge of the eating in order to restore these kids to better health. So we're often switching that dynamic at the mealtime setting. Sorry, I got muted there for a second. We are borrowing from that anxiety disorder literature and incorporating families because often families are needed to ensure generalization of that exposure learning to the home environment. Okay, so some of the things that we're doing as well in our PHP are these individualized meal plans, as Marcus Westerman describes. Our meals and menus are jointly planned between dietary staff, clinicians, and kitchen managers, and we like to do this balance between this flexible yet protocol-based approach to feeding to target the specific ARFID symptoms. We're doing a lot of demand fading at meals, altering the volume of food present to help patients work on tolerating fullness or increase volumes of food. We're often working within a patient's preferences to increase, again, volume first over variety. And we're using those mealtime setting for exposure work. And that's why we like clinicians to be involved in the menu and the treatment planning part of the program here. So we're willing to get super specific, buying certain brands of foods from certain stores in order to help our patients be successful in eating. But the other major thing that we're really emphasizing here too with younger kids is a very, very careful assessment of other complexities that might be impacting the eating process. So we're on the lookout, especially within the first week of program and observing children eating, for any signs of sensory sensitivity or sensory modulation difficulties, any signs of oral motor dysfunction, the possible presence of some undiscovered food allergies, as well as any, again, GI disorders that we need to be incorporating into treatment. So I've included on this slide a number of kind of red flag warning signs to look out for here. My computer keeps muting me. So keeping groups short, age-specific manuals, high staff to patient ratio, a very structured schedule, and again, behavioral contingencies woven throughout our program day to keep kids motivated and on track.
Thank you all for those great presentations. And I have a number of questions that have come in from our audience. So I would like to start with the questions. Any of the speakers may answer. If a participant has requested a specific speaker, I will let you know. But I think some of the top questions that have come in across the board concern what are the markers for when we step down, or how do you know when somebody's ready to finish a higher level of care and step down to the next level of care? So I would take maybe Dr. Eckert first.
Sure. So for us, and in the medical hospital setting, we are really following those admission and discharge criterion. So based on when a patient is no longer medically meeting criteria. So that makes it a bit harder in our setting because a lot of times it's sooner than we would like for a patient to have to step down out of the hospital. But I would say that frequently, if we see that a patient is still really struggling, we may be more likely to refer to a place like Rogers or Melrose Center to give more intensified support before they step down into outpatient level of care. So I would say from our setting, it's really based on those medical criteria, and that's what we have to follow because we're billing under medical insurance. That may be very different. Yeah.
And Dr. Eckert, a related question is, how often do you find that you need to use NG tube feeding support? And if so, how do you get kids with ARFID to be weaned off of NG tubes?
Awesome. So I actually think it's very infrequent, and we try very much to not use NG tubes unless we absolutely have to. We would much rather to work within the parameters that everyone else was suggesting of preferred foods, and even having parents bring in those preferred foods to the hospital and working with our dietitians to get those incorporated into their meal plan, even in the hospital setting. But sometimes we do need to use an NG tube, and in which case, frequently I would say we start with, these are the kids that everyone's been talking about that have a lot more of the GI complaints or other major GI issues. We'll often start with doing an all-day feed, so a very slow drip to help their body to get used to eating and gaining weight first. And then as their body is getting healthier, then we can start to work on decreasing those tube feeds, eventually turning them off during the day and just having them eat during the day, and then running the tube feeds at night. And doing it in that way, and then eventually getting them off at night and increasing the calories throughout the day. So we kind of do it slowly. Each day we'll reassess and kind of decrease the tube feed by 200, increase the oral feed by 200. And again, we're doing it with those very, very high calorically dense foods so that hopefully we can get the calories in without having to require the feeds using food instead.
Thank you so much. And now for Dr. Westerman.
Yep.
There's some questions about whether we're seeing more patients with ARFID. Is it possibly increasing? And especially, I guess this question's for you and for others. What do we do if we have a mix of patients during meals, some with the ARFID, some with the anorexia? They're both.
Yeah, I mean, I would say in terms of frequency, yes, we are definitely seeing more frequency. I think that has to do with the DSM-5 diagnosis. We get a lot of parents that are kind of relieved by saying, okay, now we know what this is. And I think like Dr. Menzel was wonderfully sort of explaining that there is this sort of shift in things in terms of these patients have always been there, but they have had a hard time figuring out exactly where to get help. So yeah, we're seeing a lot more of it. I would say every time I speak to like a pediatric group or things like that, they're always asking questions about ARFID. So I think there's this, there's definitely an increase in the patients that we're seeing.
Thank you. In the interest of time, I'm going to just try to get to a couple more of these questions. Everyone is interested in how we track outcomes across the ages, and maybe Dr. Farrell, you could say something about what measures are we using within Rogers to know when somebody's ready to step down, or outcome measures in general.
Sure. You heard me talk about the importance of building an exposure hierarchy with the patient, as that essentially forms kind of a roadmap for the course of treatment in large part. And in our programs at Rogers, we will be routinely assessing the completion percentage of that hierarchy, because what our outcome data show is that we want 50% of the hierarchy to be completed. That is, the patient has been able to tackle more or less 50% of their feared and avoided scenarios before transitioning to one of our lower levels of care, whether it be PHP or IOP, where we want the majority of the remaining hierarchy to be completed. In terms of assessing various symptoms, not only to capture their nature and severity, two key instruments that we use in our programs. The first is the Eating Disturbances in Youth questionnaire, which is a really nice kind of diagnostic screener for ARFID. It really follows kind of the core symptoms and features listed in DSM. And then we also use an older instrument, the Yale Brown Cornell Eating Disorder Scale. We find that that instrument does a really nice job at capturing the wide variety of eating-related fears and preoccupations, as well as some of the ritualistic safety behaviors that our patients use.
Thank you. And I realized, Dr. Westerman, but we have a couple questions for Dr. Menzel, and then I would like to come back to the question, what do we do when we have meals with kids with different types of problems? And any of the speakers could probably address that. So Dr. Menzel is being asked, what type of behavioral programs are used to keep the kids motivated? And I would like to add, do you think there's a big difference in trying to work with exposures that involve disgust versus fear?
Great questions. So the types of behavioral programs we use to keep kids motivated are, the best answer here is they're highly individualized. I'd say each individual ARFID patient in our program has their own sort of plan that identifies kind of target behaviors that we're trying to shape, whether that be solid food completion, participation in exposure, and we work with what motivates those kids best. I'd have to say, just anecdotally, that's often access to electronics. That seems to be a very universal motivator for young children. But a lot of them are using things like stickers or token economy systems to track their progress, to reinforce behaviors, and then like being able to kind of change those stickers in or those tokens in for different prizes that they've self-identified. So again, whether that's more electronic time or a fun outing on the weekend with their families, it's so much based on just what that individual child wants and finds motivating. As far as differences in exposures for disgust versus fear, it's a great question. And, there's a lot of data that does suggest that disgust functions very differently in response to exposure as opposed to fear, where we can get these beautiful, nice habituation curves from repeated exposure to fear-based cues. Disgust is a little bit more attenuated in its response to exposure. I think adding some acceptance-based strategies to target disgust. So not necessarily this goal of having disgust habituate, but how can we help patients more tolerate that sensation? So thinking about things that are important to them that can help them sort of ride that wave of disgust in response to eating. But in general, we tend to stay away from foods that cause a very strong disgust response because we want to avoid having any aversive conditioning happen in response to eating. So oftentimes if a patient does have a very visceral and strong disgust response to food, like retracting facial grimace, things like that, we'll often kind of remove that as a target for food exposure and really look for other foods that are a lot more acceptable or palatable to the patient.
This is all very helpful. Maybe for each panelist to quickly answer the last kind of question that came through with a lot of our participants. So in higher levels of care where we're managing group meals, are there any tips or any ideas about what to do? Do you have patients with all different diagnoses sit together? Just any comments? Maybe we'll start from the top of the first speaker, Dr. Eckert, and have each speaker give a little comment or two.
I would say at Children's, we have not had major issues with this with our patients. And I'd say if people are concerned about it, to actually try it out, because in general, I would say our anorexia patients tend to be very supportive of the ARFID patients because they see them eating foods that they have no interest in eating whatsoever and are incredibly fearful to them. And so they're not upset that the patient is eating things like chicken strips and peanut butter sandwiches. They don't have a problem with it because they're not having to eat it at that moment or something. And as far as the ARFID patients, I think it's also sometimes helpful for them to see that other people have different worries about food, and we can talk about that individually with them and kind of process how there are a lot of different eating issues and how they're not different, and how they are different, but how as in general that doesn't make them I think a lot of ARFID patients feel really different than their peers and things like that. And so sometimes there can be this feeling of being more accepted when they see that other kids also have different kinds of eating issues. And so I think that they actually learn a lot from each other and they're very supportive of each other.
Thank you, Dr. Eckert, and I will second that. I think it's an unexpected benefit of having higher levels of care is the peer support. Maybe we could also hear from Dr. Westerman about this topic.
Yeah, I mean, I think we find too that there is that sort of social contract. I mean, eating is a social activity. So oftentimes you're having that eating together for the ARFID patients tends to encourage them to do a lot more exposure more quickly. I think one of the things that we try not to do is hold them back from exposure, because a lot of times you'll have some kids that eat a very limited amount of food, but then you get them together in this social setting. People are eating together. There's this encouragement. So on the one hand, the ARFID patients tend to be more positive in general, so that can be encouraging to the other patients. But I would say the other patients are often just encouraging by that sort of social presence of, hey, I am in a situation that would necessitate me trying some new foods. And it's almost the same kind of thing that we want to encourage them to do in their regular life. And that's often what gets them in treatment, is that social deficit that goes along with not eating this variety. So in a higher level of care, we can really kind of mimic that. Sometimes with younger kids, or if there are more problems, we may do more individualized meals and things like that. But I would say in general, the group setting tends to be helpful for both.
Great. Dr. Farrell, do you want to say anything about the motivational strategies that can be used in meals, and what do you do if you have a bigger group in a meal?
Yeah, I think that what I can add to what my colleagues have already contributed is, naturally meal times are going to be very anxious times for our patients, and often regardless of diagnosis. I think that efforts to alleviate that anxiety are understandable, given the priority of helping our patients meet their energy needs. I think at times some programs can kind of err too far on the side of caution, and maybe go over the top with things like distraction, whether it's music or game playing or other activities that really serve to distract one from the thoughts and feelings that they're experiencing during the meal. If one of our major objectives is to promote learned toleration and improved confidence that one can endure some of these difficulties. Unfortunately, I worry that the distraction and other similar strategies are counterintuitive to that goal.
Thank you. And Dr. Menzel, you have the last comment. Maybe I'll add one additional question for you, which is, what do you do if someone doesn't finish the meal and you need replacements? Is the difference with kids with ARFID versus anorexia nervosa?
Yeah, sure. I'll speak more to that because I 100% agree with what the earlier speakers have said. And I really loved how Sarah phrased it. If you haven't tried it, do it. You might be really surprised at combining these diagnoses in the mealtime setting. So as far as replacement goes, we tend to be a little bit more flexible with the kind of replacement that we're using for ARFID patients. I would just say, first of all, we do have some ARFID patients that are normal weight, and we're actually trying to wean them off of supplements. And so in those cases, we may not actually do supplementing or meal replacement if the patient doesn't finish their meal, because we're really trying to encourage the solid food intake. And so sometimes that supplement is actually reinforcing of food avoidance. But in our patients who do need to weight restore, we're trying to just get really creative about how we supplement. So we use Boost, we use Ensure, we use Pediasure, we use Carnation Instant Breakfast. We might do like Cliff Bars or Z Bars, or even like a special smoothie or shake that the kitchen prepares. Whatever is going to be palatable for that child to kind of get that extra nutrition in. But yeah, as I mentioned, it's really kind of, we really try to watch as to what extent that meal replacement becomes reinforcing of avoidance. And we may actually opt not to supplement depending on where the patient's weight is at and what their treatment target is.
Thank you. And I think we're almost at the close. 2 questions came in at the very last minute, and I'm going to see whichever speaker will respond to these. One is about the use of rewards. Do you think that this has to continue throughout treatment, or does it tend to be more of a problem or an idea to use rewards at the beginning? In other words, how long do you need to carry on giving rewards in order to get somebody to continue eating?
I can take that one.
Okay.
So I would say it really depends on the patient. So we have some patients where we're able to wean them off of rewards as treatment goes on, as the patient gains confidence, as they have more success. We're able to sort of taper off that reward schedule as the patient nears the end of treatment. And it's certainly our goal to, have patients eat as normally as possible when they leave. But there's definitely a group of patients that I think requires those motivators for a pretty long time, and often the parents need to switch out the motivators and find new novel rewards quite often to promote eating long term. And I'd say these are often the kids who have really low appetitive drives. I think these are kids that inherently don't find the mealtime setting to be that rewarding. They don't necessarily find food in it of itself rewarding. Eating is still a chore to them. Those are often the kids that I think need rewards long term, and often you're going to find that one reward strategy will lose steam at some point, and you're going to have to switch it up and find a new and novel reward strategy and just keep cycling through. Great.
Last of all, some patients have fear consuming liquids, and is that a common concern do we see across the programs? Along with, do we believe that CBT exposure therapy works across the age, from younger children all the way to older patients?
Sure, I can give an answer. I would say fear of liquids anecdotally is less common than fear of certain foods, whether it's quantities of food or different food items. And yet we certainly have seen fear of consuming liquids in our programs at Rogers amongst patients with ARFID. I think it's very amenable to an exposure-based approach. Again, this is anecdotal, but I think a lot of times the feared outcome is a perceived inability to tolerate sensations associated with being kind of full from a liquid standpoint. I can think of one patient in particular who described kind of a sloshing sensation and perceived themselves as being completely incapable of being able to endure that sensation.
Thank you all so much, and for the great questions from our participants and the wonderful presentations from our speakers. The last slide does have the references with each of our speakers contributed some key references for the webinar. Thank you so much, all of you.